Hi, my name is Samuel Maria. I'm an interventional cardiologist at the Massachusetts General Hospital. I focus on transcatheter therapies for valvular heart disease, and it is my true pleasure to speak to you today about unique considerations for valvular heart disease in women. Here are my disclosures. So my objectives for the day are first to review the impact of gender on the epidemiology of mitral regurgitation and calcific aortic stenosis, to summarize challenges in the diagnosis of MR and AS among women, and finally to examine the comparative outcomes of men and women undergoing valve surgery and also transcatheter valve interventions. So first, just to highlight some of the epidemiology of valvular heart disease. So in the United States, the pooled prevalence of valvular heart disease is approximately 2.5%. And in unadjusted rates really demonstrate that there is no significant difference between the sexes, with approximately 2.5% in each. Now, having said that, after adjustment for age, there does appear to be a higher degree of valve disease in men. And when one looks by specifically at mitral regurgitation and aortic stenosis, of course, these are diseases largely of the elderly. And with mitral regurgitation in patients over the age of 75, over 9% of patients have MR, have significant MR, here defined as either moderate or severe mitral regurgitation. And nearly 3% of patients over the age of 75 have significant aortic stenosis, again defined by moderate or severe valve disease. Now, in shifting gears and looking specifically at mitral regurgitation, I want to give you a sense of the differences in intervention across the sexes. And here is a results of a study performed at the Mayo Clinic in Olmsted County, reviewing data from 1990 to 2000. And what they did was look at consecutive patients who underwent mitral valve surgery for primary, or as they call it, organic mitral regurgitation. What they found is that women are less likely to undergo mitral valve repair as opposed to replacement. And interestingly, women seem to undergo intervention at a later stage of disease, with 58% of women compared to 48% of men undergoing surgery specifically for heart failure symptoms or for evidence of left ventricular dysfunction. Now, early surgery, of course, with primary mitral regurgitation, if a valve can be replaced or repaired, we often will intervene at an earlier stage before symptoms or overt heart failure has developed. And we see that this only happened in 26% of women undergoing surgery for mitral valve, as opposed to 39% of men. So again, highlighting the fact that women are undergoing intervention at a later stage of disease. Now, the reasons for this are unclear, but there do seem to be we do seem to gain some insight when looking at the echocardiographic characteristics of these patients. So when one looks at left ventricular size, it is not surprising that men are found to have larger ventricles. But having said that, women, of course, have smaller body size. And in this study, body surface area was approximately 30% lower in women than in men. And interestingly, when these echocardiographic metrics of left ventricular size are indexed to body surface area, we see at the bottom of this table, you see a very different pattern, such that left ventricular size relative to the patient's body surface area is actually greater in women than it is in men. And so this does highlight a very important point, that body surface area may be impacting what we perceive as the heart's remodeling due to this valve lesion. And this also, I want to raise another potential point, which in the recent literature, Paul Grayburn and others have raised this concept of proportionate versus disproportionate mitral regurgitation. And specifically, this has been introduced as a way of explaining the fact that robust clinical improvement was seen in the COAP trial with MitraClip. whereas in MITRA-FR, we saw an absolute negative study. And I think a very similar concept does exist here between women and men. And the bottom line message here is that if one has a smaller ventricle, it takes less mitral regurgitation to be clinically significant. And so in women, because they have lower ventricles, one would expect that we should consider lesser degrees of MR as clinically significant and therefore act on them. And if we wait for the MR to get worse, it is, of course, leading to delayed intervention for these patients. Now, thankfully, based at least on this study, this does not, the late treatment of women for primary mitral regurgitation does not seem to impact survival, although it does impact heart failure events after surgery. You see fairly statistically significant, robust differences in regards to the incidence of postoperative heart failure in women as compared to men. Now, with ischemic MR, we see many of the same patterns. And this is data from the CTSN, the Cardiothoracic Surgery Network, which of course looked at mitral valve surgery for ischemic MR and found that women who were undergoing surgery for ischemic MR had, again, smaller volumes, left ventricular volume, smaller effective regurgitant orifice area, but interestingly, in a pattern very similar to what I just described, the ratio of effective regurgitant orifice area to the left ventricular size was larger in women than in men, again demonstrating that the degree or the burden of MR was more significant in women than it was in men. Now, after surgery, the outcomes also differed quite robustly, with higher 2-year mortality in women, higher event rates for major adverse cardiovascular and cerebrovascular events. Women experienced worse quality of life and worse functional capacity at 2 years. Again, all indicating that these patients that unfortunately female patients are undergoing intervention at a late stage of disease where their ventricles have decompensated to a greater extent. Interestingly, with valve repair, this study also demonstrated a fairly robust trend suggesting that the recurrence rate of mitral regurgitation was higher in women as compared to men. Now, with transcatheter valve therapies, we get a slightly different picture. Here you see data from the TVT registry. For those of you who are not familiar with it, this is a nationwide registry that is jointly maintained by the American College of Cardiology as well as the Society for Thoracic Surgery. And this is supposed to capture all commercially performed transcatheter valve interventions. You see that the overall mortality rate for TMVR, of course, again, with the current indication, which is high-risk patients, the 1-year mortality rate is 25% with a 1-year rate of heart failure hospitalization of 20%. And in this study, we do not see any difference in regards to the rate of mortality or the composite of mortality or heart failure at 1 year in women who are undergoing these procedures. So outcomes do really seem to be quite consistent across the sexes. Now, one fascinating study that was recently published in the European Heart Journal suggested that left ventricular reverse remodeling was associated with improved clinical outcomes after MitraClip. And they specifically defined left ventricular reverse remodeling as a 10% reduction in left ventricular end systolic volumes. This occurred in 42% of patients. And as you can see, the curves seem to spread with greater LV reverse remodeling occurring at later points in time. And improved remodeling was associated with reduced all-cause mortality, reduced cardiovascular mortality, as well as reduced heart failure hospitalization. And the strongest predictor of reverse remodeling appears to be female gender. And this does suggest that if one is to intervene at an appropriate time point, that women will reap substantial clinical benefit from these procedures, and that their ventricles can adequately and perhaps will adequately remodel, and perhaps actually remodel to a greater extent than is seen in male patients. So to summarize the mitral regurgitation data, so women who undergo mitral valve surgery or less frequently undergo mitral valve repair. Failure to index echocardiographic left ventricular and MR metrics to body size tends to result in the underestimation of MR severity in women. Mitral valve intervention in women may therefore be occurring at later stages of disease and may contribute to higher rates of postoperative heart failure. Women experience worse clinical outcomes compared to men after surgery, but clinical outcomes after transcatheter mitral valve repair are comparable in men and women. And finally, women are more likely to experience left ventricular reverse remodeling, which has been associated with improved cardiovascular outcomes after transcatheter mitral valve repair. So shifting gears to focus on aortic stenosis, I want to begin again by highlighting the epidemiology of aortic valve disease. And opposed to what we described earlier, aortic valve disease does seem to occur more commonly in men, with double the odds of having aortic stenosis in this cohort. Now, women do tend, as with mitral regurgitation, to present at later stages within their disease trajectory. But interestingly, with aortic stenosis, there appears to be a very unique risk profile of these women who present with AS. So first, women are more likely to have concomitant moderate to severe regurgitation. They, as with mitral regurgitation, have smaller left ventricular cavities, more left ventricular hypertrophy, and interestingly, these factors together lead to a higher likelihood that a woman is going to present with low flow, low gradient, severe aortic stenosis. Now, we know that this introduces oftentimes a diagnostic dilemma. And in patients with a low ejection fraction, the next diagnostic test of choice would, of course, be a dobutamine stress echo to assess for contractile reserve and really try to determine whether these patients have true severe aortic stenosis or pseudo-severe aortic stenosis. Now, diagnostic efforts are a little bit more complicated if the ejection fraction is preserved. These are patients that have what we call paradoxical low flow, low gradient aortic stenosis. And more we are relying on aortic valve calcium scores in such patients to help guide therapy. Now, it's important to realize that the thresholds for valve calcium score differ between men and women. For a man, a score of greater than 2,000 Agatston units is highly suggestive of severe aortic stenosis, whereas a score of greater than 1,200 is suggestive of severe aortic stenosis for a woman. The reason for this difference is simply that the valve biology differs, and that valves in female patients seem to have a greater extent of fibrotic tissue and less calcium. So for a given calcium score, regardless of one is looking at mean gradient or valve area, for a given valve calcium score, you can see that the dotted lines representing women, that the severity of aortic stenosis will be worse. And in the highest tertile of valve calcium scores, over 1440 Agatston units, one sees that women in the dark bars have a peak jet velocity that approaches 5 meters per second. So very severe aortic stenosis in this cohort of patients. Now, a few final questions that I really want to make sure we touch on, because these are, of course, will hopefully impact clinical management of female patients with aortic valve disease. So the first is, how do clinical outcomes for women and men compare after surgical aortic valve replacement? How do they compare after transcatheter valve replacement? And finally, and perhaps most importantly, do women experience better clinical outcomes with Tavr or with Savr? So first, how do clinical outcomes for men and women compare after surgical aortic valve replacement? Here, data from the 2008 Society for Thoracic Surgery for thoracic surgeons STS database. So this is a database, a nationwide database that encompasses all cardiac surgical procedures. And it is these data that actually are used to generate the STS score that we're all familiar with. So first of all, we see that male patients are more likely to undergo aortic valve surgical AVR, with almost 60% of patients undergoing AVR being of male gender. Women who undergo surgery do have an increase in the risk of 30-day mortality, an increase, nearly 25% increase in the risk of stroke, and also almost 30% increase in the risk of prolonged ventilation. Now, keep in mind that these data are the ones, as I mentioned before, are the data that inform the STS score. So because female gender is associated with an increased risk of mortality, there is an inherent risk assigned to female gender in the STS score, and this will have important implications that I'll highlight in a second. So after Tavr, we get slightly different results. So first of all, we see that in the pie charts on the left of the screen, you see that women are less likely to undergo a transfemoral Tavr because their femoral artery and iliofemoral vessel size is smaller. It is more common that we have to adopt alternative approach strategies to perform a Tavr in a female patient. Thankfully, the rates of transapical procedures have diminished greatly in the last couple of years, but in this study from 2016, we see that nearly over 30% of female patients underwent a transapical approach, which we know associates with poor outcomes. Now, in the acute periprocedural period, female patients experience a higher degree of major bleeding, nearly double the risk of major vascular complications. We also see that women are more likely to undergo conversion to open surgical procedures, and that this is largely driven by the risk of ventricular rupture, of coronary occlusion, and also whereas men actually have a increased risk of valve-in-valve procedures. Now, when one moves beyond or looks beyond the immediate periprocedural period, the results differ. So you can see from the first curve looking at mortality that the curves cross. And so what I mentioned earlier was that female patients, that women had an increased risk of periprocedural complications, but the long-term risk is actually more favorable. And mortality rate is less in women than it is in men. There is a strong trend suggesting an increased risk of stroke with women as compared to men, that, however, again, does not reach statistical significance with a p-value of 0.09. But looking at somewhat more standardized data, here you see a meta-analysis that was conducted by the FDA. These results go out to 2 years and include data from all of the Tavr clinical trials. And they specifically looked at the subgroup of they specifically looked at differential outcomes between men and women. And similar patterns do exist, such that women have improved survival, here extending out to 2 years as compared to men after Tavr. The stroke rate in this study was comparable between men and women. There are subtle differences in regards to the risk of kidney injury, with higher rates of kidney injury in men as compared to women. And again, we discussed the risk of bleeding, which is increased in women as opposed to men. And then finally, yet another meta-analysis that was performed that extends these results to 3 years and demonstrates that women do have better outcomes after Tavr than do men. So the next question is why? Why exactly should a procedure that is potentially associated with greater short-term risk for women, why does this associate with improved outcomes in the long term? And the reason for this is really unclear, but if we dive into some of the baseline characteristics, we begin to get some insight into perhaps why. So when we look at this, again, the meta-analysis from the FDA, you see that women were less sick. So they had lower rates of diabetes, lower rates of coronary artery disease, lower rates of cerebrovascular disease, and lower rates of chronic kidney disease and also chronic obstructive pulmonary disease. So really across the board, comorbid conditions seem to be occurring with lower frequency in women than in men. And the reason for this is, remember, these trials that were included, the trials that were included in this meta-analysis utilized the STS score as the primary entry criteria. And a woman with the same age and the same STS score as a man will have fewer comorbid conditions, given that there is risk attributable to female gender. Now, this risk, of course, is again derived from surgical studies. So in the Tavr trials, the women who undergo Tavr do seem to be healthier than the men that were enrolled in these trials, and certainly that may have implications for long-term outcomes. But there are some other features. So I highlighted the fact earlier that the degree of calcium within the valves, the aortic valves of women, are less robust than the degree of calcium in male patients. We also know that the sizing of the annulus is smaller in females and that the coronary heights are lower in females. And these things do add up to impact the risk of paravalvular leak. So heavy calcium burden with dense nodules of calcium in men does result in an increased rate of paravalvular leak in men. And similarly, larger annulus size, especially when it exceeds the recommended upper bounds of these valves, of the valve prosthesis, both of these factors can contribute to higher rates of paravalvular leak in men. And we do know that paravalvular leak is attributed to an increased risk of peri-procedural mortality, and that this difference does extend out to 3 years. Now, interestingly, one study has actually looked at whether there's effect modification or whether PVL impacts mortality in a comparable sense between men and women. And in this study, they suggest that it in fact does not impact men and women equally. And that in women, that paravalvular leak really has no impact on survival, suggesting that the female ventricle is better able to accommodate the volume load that is caused by paravalvular leak. Whereas in men, there of course is the robust mortality difference that we've all seen repeatedly reported. In taking this a step further, we do know that, again, and we saw this in mitral regurgitation as well, but that women do seem to experience a greater degree of left ventricular hypertrophy. And this seems to be related to differences in cardiac gene in the gene expression of fibrotic pathways. So women do seem to have less fibrosis, and because of that, they have a greater extent of regression of left ventricular hypertrophy. And here you see histologic data, in fact, proving that women do have less fibrosis than men. And this is important because fibrosis is, of course, felt to be largely irreversible, whereas myocyte hypertrophy, cardiomyocyte hypertrophy, does actually regress and regresses relatively quickly. So finally, do women experience better clinical outcomes with Tavr or with Savr? So if you are faced with a female patient with severe aortic stenosis, which therapy is preferred? Here I show the results of the randomized clinical trials comparing surgical aortic valve replacement to transcatheter aortic valve replacement. You see that each of these trials, partner 1, 2, and 3, which studied high-risk patients, intermediate-risk patients, and then on the right side of the screen, low-risk patients, each one of these studies suggested that Tavr is at least as good as surgical valve replacement in all comers, with the low-risk trial actually suggesting that Tavr was superior to surgical valve replacement. Each one of these studies has performed subgroup analyses looking at gender, and in every single one, there seems to be a strong trend for more favorable results with women as opposed to men. And in each of these studies, the subgroup of patients, the subgroup of female patients do actually seem to have better outcomes after transcatheter as opposed to surgical valve replacement. And the reason for this is not completely clear, but having said that, the rates of patient prosthesis mismatch have been implicated strongly. We again, repeatedly, it's the same theme, but women, of course, do have smaller annulus sizes. And because of this, we know that the rates of patient prosthesis mismatch are higher in women as opposed to men. We also know that Tavr is associated with lower rates of patient prosthesis mismatch as opposed to surgical valve replacement, because Tavr does not have a sewing ring, which of course is bulky and takes up space and therefore increases the risk of prosthesis patient mismatch. Now, prosthesis patient mismatch does result in a significant mortality risk when it is severe, and then unfortunately what has been demonstrated in this data, in this analysis from the TVT registry, is that female patients do have a substantial increase in their risk of severe patient prosthesis mismatch. And so, again, this would suggest that they would do better with Tavr as opposed to Savr, simply because this would lessen the risk of patient prosthesis mismatch in these patients. So in summary, women often present later in the course of aortic stenosis progression with more concentric left ventricular hypertrophy and more advanced aortic stenosis with lower calcium burden. Perioperative mortality is higher in women than in men undergoing surgical AVR. Vascular and bleeding complications are more frequent in women undergoing Tavr, but long-term survival after Tavr is more favorable in women. Women with aortic stenosis experience better clinical outcomes with Tavr than with Savr, and less fibrosis in women may facilitate left ventricular reverse remodeling, as well as a greater tolerance of paravalvular leak. Thank you very much for your attention.